Welcome to today's explainer where we are investigating nephrolithiasis, better known as the clinical mystery of kidney stones. I am absolutely thrilled to break down this highly clinical and honestly fascinating topic for you today. We're going to map out exactly how and why the human body inadvertently manufactures tiny, jagged rocks, and how modern medicine steps in to solve the whole shebang.
Here is our roadmap for the investigation. Section 1. How kidney stones form. Section 2. The 5 suspects. Section 3. Symptoms and emergencies. Section 4. Diagnosing the blockage. And finally, Section 5. Treatment and prevention.
Because really, before we do anything else, we have to ask, what actually causes one of the most agonizing medical conditions known to humanity? If you, or maybe a patient of yours, have ever experienced the excruciating reality of renal colic, you know exactly what I'm talking about. People frequently compare it to childbirth, and for very good reason. The stakes here are incredibly high, not just for getting the patient out of pain, but to prevent permanent, irreversible organ damage.
So let's start with a nice, clean definition. Nephrolithiasis is simply the formation of solid crystals or stones within the urinary tract. And you know, it all starts with a really simple, fundamental imbalance: the supersaturation of solutes in the urine. Basically, way too much solid and not nearly enough liquid.
All right, moving to Section 1, how kidney stones form. Let's walk through this chemical cause and effect chain, step by step. Imagine your kidneys functioning just like a giant chemistry beaker. First, you get supersaturation. This happens when you have a massive excess of solutes, like calcium or oxalate. Or conversely, a severe lack of solvent. Usually that just means water from dehydration. Second, we hit precipitation. The solutes literally lose their solubility. They just can't stay dissolved in the liquid anymore. Third is crystallization. Those precipitated solutes start to clump together, forming solid, jagged little structures. And finally, step 4, obstruction. These crystals get swept into the ureter or the renal calyces and literally lodge themselves in the plumbing. Just like that, liquid urine has transformed into a mechanical roadblock. Which brings us to Section 2, the 5 types of stones.
Now, what's really interesting about this slide is seeing how different physiological environments create entirely unique, visually identifiable crystal shapes. Look at these structures. Calcium oxalate, which is our most common, forms these envelope or dumbbell shapes in a low pH acidic environment. Calcium phosphate forms wedge shapes, but crucially, it thrives in a high pH alkaline environment, which is often linked to kidney acid filtering issues like type 1 distal RTA. Then you've got uric acid crystals. These are rhomboid, and they're driven by conditions with high cell turnover like gout or tumor lysis syndrome. Next up are struvite stones, which form these massive, crazy coughing lid or staghorn shapes. These are uniquely caused by urease-producing bacteria, like Proteus, again in a high pH environment. And finally, we have the rare cystine stones, which form perfect little hexagons due to a genetic transporter mutation.
Let's put a spotlight on our prime suspect for a second: calcium oxalate, the most common offender by far. This forms when calcium and oxalate pair up, but why does that actually happen? Well, it can be hypercalciuria, meaning way too much calcium. Think hyperparathyroidism, certain malignancies, or even loop diuretics. Or actually, scratch that, it could be hyperoxaluria. If a patient has a malabsorption issue, like Crohn's disease, unabsorbed fatty acids bind to calcium in the gut, leaving all this free oxalate to be absorbed into the blood and just dumped into the kidneys. Ingesting way too much vitamin C or antifreeze can also spike your oxalate. Then there's hypocitriduria. Normally, citrate binds calcium and prevents stones, but metabolic acidosis stops your body from excreting it. And of course, overlaying all of this is our old friend, dehydration. A low solvent volume acts as an accelerant for literally any of these chemical reactions. Okay, Section 3, symptoms and emergencies. What happens when things go wrong? When a stone actually lodges in the ureter, you get the classic presentation. First up is renal colic, these intense, unbearable bursts of pain radiating from the flank all the way down to the groin. And listen, this isn't just minor irritation. The ureter is physically stretching, and its smooth muscle is forcefully spasming down on a jagged rock. Second, severe nausea and vomiting. That extreme pain sends a reflex signal straight up the vagus nerve, cranial nerve X, directly activating the emetic center in the brain. Third is hematuria, or blood in the urine, simply because that jagged stone is literally tearing up the mucosal lining as it gets squeezed through the urinary tract.
But look, this classic presentation can escalate into a full-blown urologic emergency incredibly fast. On the left, we have pyelonephritis and urosepsis. The stone completely blocks urine flow, causing urinary stasis. bacteria multiply like crazy in that stagnant pool, causing a severe kidney infection. If that bacteria breaches the bloodstream, bacteremia, the patient can spiral right into vasodilatory, hypotensive septic shock. On the right, contrast this with an acute kidney injury, or AKI. If a patient has a bilateral obstruction, or maybe they only have one functioning kidney, that blocked urine drastically increases hydrostatic pressure back up inside the kidney capsule. That intense pressure physically prevents the kidney from filtering blood. Your glomerular filtration rate plummets, and toxic waste products like creatinine and potassium spike abruptly. Both of these scenarios are absolute life or death situations.
Which brings us to Section 4, diagnosing the blockage.
How do we find the evidence? Well, we have two main imaging choices. The undisputed gold standard here is the non-contrast CT scan of the abdomen and pelvis. It beautifully reveals the exact location of the stone, its precise size in millimeters, and the degree of hydronephrosis, which, if you remember, is that fluid-logged swelling of the kidney right behind the blockage. However, we have a really crucial exception. We use the renal bladder ultrasound as the safe alternative for pregnant patients and children to completely avoid radiation exposure. It's fantastic for proximal stones and detecting swelling, even if it does struggle just a bit with the really tiny stones lower down.
But we don't just rely on pictures, right? Alongside imaging, the clinical lab workup acts as our vital set of clues. A urinalysis checks for the obvious hematuria, but more importantly, it looks for white blood cell casts, leukocyte esterase, and nitrites, massive red flags for an associated infection. We run a complete blood count to look for leukocytosis, which is a high white blood cell count, indicating the infection has actually gone systemic. Our renal function panel monitors creatinine and BUN to ensure we aren't dealing with that dangerous acute kidney injury we just talked about. And finally, and honestly, perhaps most importantly for the long haul, a 24-hour urine test and a physical stone analysis. Once we catch the stone, we test it. Knowing its exact chemical makeup is literally the only way to formulate a true prevention plan.
Okay, the final piece of the puzzle, Section 5, treatment and prevention. This builds a treatment escalation timeline based entirely on the physical size of the stone. If it's under 5 millimeters, it will likely just pass naturally. We support the patient with NSAIDs, opioids for that severe pain, and IV fluids if they're vomiting. If it's 5 to 10 millimeters, we use medical expulsion therapy. We prescribe alpha blockers like tamsulicin to relax and dilate the smooth muscle of the ureter, but between 10 and 20 millimeters, we have to go in. We use extracorporeal shockwave lithotripsy, firing radio waves from outside the body to basically shatter the stone, or we use a ureteroscopy, going up the urinary tract with a laser to blast it. And for massive stonins greater than 20 millimeters, or those giant staghorn calculi, we use percutaneous nephrolithotomy, meaning the surgeon creates a direct track through the patient's back, straight into the kidney to extract the whole thing.
Now hold on. If the patient is in the middle of a urologic emergency, like severe pyelonephritis or an AKI, we absolutely do not have time to wait for a stone to pass. We must immediately decompress the system. This means placing a percutaneous nephrostomy tube directly into the kidney to drain the infected fluid straight out the back, or bypassing the stone entirely by threading up a ureteral stent.
So once the immediate crisis is solved, how do we stop the next stone from forming? Well, this slide brilliantly illustrates how identifying the stone type directly dictates our pharmacological prevention strategy. If a patient keeps forming calcium stones, we put them on thiazide diuretics, which uniquely pull calcium out of the urine and back into the blood, alongside a lower sodium diet. If they're churning out uric acid stones, we prescribe allopurinol to block the body's uric acid production entirely. For those rare cystine stones, tiopronin actually breaks the chemical disulfide bonds to dissolve them. If the patient has highly acidic urine causing oxalate or uric acid precipitation, potassium citrate alkalinizes the urine back to a safe pH. And for those massive struvite stones, targeted antibiotics to clear out the urease-producing bacteria for good.
We've explored the complex supersaturation, the intense nerve reflexes, and the highly advanced surgical tools required to clear these blockages. But here is the absolute crucial point I want to leave you with today. While modern medicine can laser, dissolve, and extract these excruciating crystals, the single most effective prevention strategy for every single type of stone is raw solvent volume. So the question is, despite all this amazing clinical science, are you drinking the simple 2+ liters of water daily required to keep your system flowing? Drink your water, folks, and I'll see you in the next explainer.